Every senior I have ever seen who monitors their blood pressure at home is trying to get it lower. Lower than yesterday, lower than last week, lower than whatever number their doctor circled on a chart. The belief underneath that effort is so deeply planted that almost nobody questions it. Lower blood pressure is safer blood pressure, and the goal is to get the number as close to normal as possible. That belief is partly right and partly wrong, in a way that has sent more people through my emergency department doors than almost any other single misunderstanding about how an aging body actually works. The truth about what the best blood pressure actually is after 65 is not one number, it is a range. That range shifts as your body gets older. And in some seniors, the number their doctor is pushing them toward is more dangerous than the one they started with. My name is Dr. Miles Ebek. I have spent the last 13 years working emergency medicine, and blood pressure is one of those conversations I end up having on the wrong side of the timeline, after the fall, after the syncope episode, after the kidney injury that arrived quietly and without warning because a number on a home monitor looked precisely the way everyone had been told it should look. I am not telling you to stop monitoring. I am not telling you to stop taking your medication. I am telling you that the target number most seniors are chasing was designed with a different body in mind, and understanding that distinction is the difference between managed blood pressure and blood pressure that has been managed too aggressively for the body it lives inside. If that is a conversation worth having before it becomes relevant in an emergency room, subscribe right now. That is the only kind of conversation I build here. Here is the first truth. The 120/80 target is not wrong. It is incomplete. The landmark trial that established aggressive blood pressure lowering as a goal for older adults, the SPRINT trial, did show that driving systolic pressure below 120 reduced cardiovascular events. What the headlines almost never mentioned was the other side of that same data. In older adults in the same trial, the intensive target also increased rates of fainting, falls, acute kidney injury, and a dangerous drop in blood pressure on standing. The benefit was real. So were the harms. And in a 75-year-old body with stiff arteries, reduced kidney reserve, and a different relationship with gravity than a 50-year-old body has, the math of that trade-off looks very different than the headline suggests. Sylvia was 77, meticulous about her health, the kind of patient whose home blood pressure log went back 2 years without a single missed entry. Her doctor had been working hard to get her systolic, consistently below 120, and they had succeeded. Her readings looked like a textbook. What her readings did not show was that Sylvia had started sitting on the edge of her bed for 2 minutes every morning before standing. Not because she had read about orthostatic hypotension, but because she had learned through experience that standing up too fast made the room tilt. She had stopped telling her doctor about the dizziness because the numbers were so good, and she did not want to be the one who complicated something that looked successful. One morning, she did not sit long enough on the edge of the bed. She was in my department by 9 a.m. with a fractured wrist and a blood pressure reading on the floor of her bedroom that told the whole story. The number on her log had been perfect. The number her body produced the moment gravity was involved was the real one. Orthostatic hypotension, the drop in blood pressure that happens when you move from lying or sitting to standing, becomes more common as arteries stiffen with age. A body with a systolic of 118 lying flat can produce a reading of 95 when it stands. And 95 is where the floor starts to move. The target on the chart and the pressure in the artery at the moment of standing are not always the same measurement. There is a second measurement problem that almost nobody discusses at appointments. Blood pressure is not the same number at every hour of the day. It follows a rhythm lowest in the early hours of the morning during deep sleep, then rising sharply in the 2 hours after waking, reaching its highest point of the day in the late morning. That morning surge is the window of highest cardiovascular risk, which is why strokes and heart attacks cluster in the hours after waking more than any other time. A reading taken at 2 in the afternoon is measuring a different physiological moment than a reading taken at 7 in the morning. If your doctor is making medication decisions based on afternoon clinic readings, while your blood pressure is doing something very different at 7 a.m., the treatment is being calibrated to the wrong moment in your body's daily cycle. Clarence was 74, and his afternoon clinic readings had looked stable for almost 2 years. His morning readings told a completely different story, but nobody had ever asked him to take one, and it never occurred to him to mention it. He had been waking at 5:30 most mornings with a dull pressure behind both eyes that he had been chalking up to poor sleep. When I asked him to start recording his blood pressure the moment he got out of bed each morning, the numbers were 25 to 30 points higher than anything in his clinic chart. His medication had been dosed for a calm afternoon body, and his heart had been managing an unaddressed morning surge every single day for 2 years without anyone knowing it was there. Tell me in the comments what your blood pressure target is and who gave it to you, whether a GP, a cardiologist, or a chart on the wall of a waiting room, because the answer to that question changes everything about whether that target makes sense for your specific body. This channel exists to give you the version of this conversation that accounts for your age, your medications, and your actual daily life, not the version that fits inside a 15-minute appointment. Subscribe if that is the kind of information you have been looking for. Here's the second truth. A significant number of seniors are being medicated for a number that only exists in a doctor's office. White coat hypertension, the spike in blood pressure that occurs in clinical settings due to the stress of being measured, runs 10 to 20 points higher than home readings in a meaningful portion of the population, and that proportion increases with age. A reading of 158 over 90 in a clinic, which looks like a number that needs medication, can be 136 over 78 at home, which is a number most guidelines would not treat aggressively in a senior. Franklin was 71, retired, calm by nature, the last person you would expect to show a stress response in a waiting room. His clinic readings had been consistently above 150 on top for years, and his medication dose had been raised twice on the basis of those numbers. A home monitor told a completely different story. When I asked him what his readings looked like at home, sitting in his own chair after 5 minutes of quiet, he described numbers that were 15 to 20 points lower than anything in his chart. His medication had been dosed for a body under clinical stress, not for the body that walked his dog every morning and cooked his own dinner every night. The most accurate blood pressure reading is not the one taken in a clinic. It is the average of multiple readings taken at home at the same time each day, after 5 minutes of quiet, in the same arm, in the same chair. One reading is a snapshot. A pattern is information. And the pattern from a home monitor, done consistently and correctly, is what should be driving treatment decisions, not a single number recorded in a room that made you nervous the moment you walked into it. Here is the third truth, and it is the one almost nobody says out loud in the appointment room. For adults over 80, particularly those who are frail, have significant kidney disease, or are on multiple medications, many current cardiology guidelines now accept a systolic target of up to 150. Not because blood pressure control stops mattering at 80, because the evidence shows that driving the number lower in a frail 82-year-old body creates as much harm as it prevents. Falls, syncope, kidney strain, medication burden. The aggressive target that protects a 65-year-old can be the thing that costs an 82-year-old their independence. Walter was 83, still sharp, still living alone, still walking to the corner shop every morning as though it were a non-negotiable appointment with the rest of his day. His systolic had been running between 138 and 144 for years. His previous doctor had been comfortable with that range, given his age and his kidney function. His new doctor, younger, thorough, working from the most current guidelines for the general adult population, began adjusting his medications toward a target below 130. Walter did not fall. He did not faint. He simply started feeling, in his own words, like the lights had been turned down. He stopped walking to the corner shop, not because his legs had failed him, but because the effort required to get there had quietly and mysteriously increased. When I saw him, his blood pressure was well controlled. His grip strength had dropped measurably in 4 months. His kidney function had worsened slightly. And the corner shop was 11 minutes away and felt, he told me, like it had moved. The goal of blood pressure management is not a number. It is a life. And in seniors over 80, the number that protects life is often not the number the guidelines were written to reach. So here's what I actually want you to take out of this video. Number 1. If you're between 65 and 79 and your doctor is pushing your systolic below 120, ask this one question. What does my blood pressure do when I stand up? If nobody has ever measured your standing blood pressure, that is a gap worth closing before the floor closes it for you. Number 2. If your blood pressure readings in the clinic are consistently higher than your readings at home, bring your home monitor to your next appointment and show your doctor the log. That conversation has changed treatment plans in my department more times than I can count, and it takes about 3 minutes to have. Number 3. If you are over 80 and your doctor is pursuing a target below 130, ask whether that target was established in a trial population that included people your age with your level of frailty and your kidney function. If the honest answer is no, that is not a reason to stop taking your medication. It is a reason to have a more specific conversation about what the right target is for you specifically, not for the average adult in a cardiovascular outcomes trial. The best blood pressure for an older adult is not 120 over 80. It is the pressure at which your heart and brain are protected. Your kidneys are stable. Your blood pressure does not drop dangerously when you stand up, and you still have the energy to walk to wherever it is you need to go in the morning. That number is different for every body it lives inside. And the only way to find it is to have the conversation about your body, not the body the chart was drawn for. Sylvia's log was perfect. Clarence's afternoons were calm. Walter's numbers looked like a victory. I'm Dr. Miles. None of that was the complete truth. Subscribe, and the next time someone hands you a target, you will already know how to find out whether that target was written for you. Thanks for watching.